it is a metabolic disorder in which there is deranged glucose levels, and there is these glucose levels, the changes in these glucose levels, they're affecting your all the body organs and also the microvasculature and your nerves. Almost each and every part of your body is affected by this syndrome. So it is a syndrome which we basically define on the basis of biochemical testing. So it depends. So there are multiple types. So the common people, they know about type 2 diabetes mellitus, which is common one, which is seen in old age. Then there may be type 1 diabetes, and there may be pancreatogenous diabetes. There may be latent autoimmune diabetes. There may be diabetes associated with pancreas abnormality, like in patients with cystic fibrosis, or pancreatic malformations can be there. Drug-induced diabetes is also a common entity, like patients who are on steroids, who are on tacrolimus, cyclosporin. These kind of drugs, they may have diabetes, and they may have other maturity onset diabetes of young. They may have mitochondrial diabetes. So it is a huge. I think we can increase the number of syndromes are there. Lipodystrophy syndromes are there. So I think there are a lot of causes and classification of diabetes, which is very difficult to enumerate. So again, the classification of diabetes is a huge thing. For phenotype, they may have mild age-related diabetes. They may have insulin deficient diabetes. They may have insulin resistant diabetes, and they may have a combination of insulin deficient and insulin resistant diabetes. So this way, you can, I think, make it easier for the people. The majority of the patients, they have type 2 diabetes mellitus. So it depends on genes, HLA, phenotypes, viral infections, your lifestyle, smoking, alcohol habits, and heredity is very, very important, especially in type 2 and type 1 diabetes mellitus. So I think these are the common causes. And otherwise, other diseases, they may also have diabetes like Cushing syndrome, acromegaly, pheochromocytoma. There are multiple endocrine disorders. They may have something called as secondary diabetes. Steroids is also a very common cause of diabetes because they are used for many conditions. So many patients, they develop diabetes because of steroids. So I think there's a huge list of causes also. Again, we will go into classification to decipher more about that. Patients may have weight gain or weight loss. They may have increased urination at night. They may have difficulty in controlling urination. They may have burning during urination. They may have increased appetite. They may have generalized weakness, fatigue. They may have loss of fat, especially from the face, and abnormal fat distribution in the body can be there. They may have darkening of their skin. They may have skin tags. They may have central obesity, right? So these are the common, ways by which they can identify diabetes. Otherwise, they may have complications of diabetes. They may have tingling, numbness, weakness of legs and feet. They may have difficulty in vision, right? And they may also have shortness of breath on exertion or chest pain because of cardiac involvement. So their and bones are also affected. So they may have pain, or they may even have fractures in patients with diabetes. So so there's a wide spectrum of presentation. Some patients remain asymptomatic, and others they may present in emergency with vomiting, pain abdomens. They may have something called as diabetic ketoacidosis. So the onset is very, very variable, and it depends on the type of diabetes they are having. So basically, we are using biochemical parameters for diagnosis of diabetes. So HbA1c more than equal to 6.5%, or random glucose more than 200 milligram per day with symptoms of diabetes. That is how we diagnose diabetes. So diagnosis is basically based on lab reports, but it is a syndrome which is affecting all the organs. Now, for different, so you may have autoimmune diabetes like type 1 diabetes, which we do antibodies like GAD65, ICA, IA2. We do C-peptide testing. You may have pancreatic diabetes. So for that, we do pancreatic fecal elastase. We do, and we can also have a look at the pancreatic fraction on MRI. So there are different Modi we do genetic testing is there. So I think there are different modalities to diagnose diabetes, but all they have the same umbrella of biochemical abnormality of raised blood glucose levels. So I think I just mentioned that it is affecting your eyes. You may have retinopathy, you may have cataract, you may have glaucoma, vision might be affected. It may also affect your memory, mentation, cognition, execution. Everything is affected. You may have hypertension, obesity, fatty liver as comorbidities with diabetes. Obstructive sleep apnea can be there. You may have neuropathy, you may have cardiovascular disease, you may have diabetic foot gangrene, diabetic foot ulcers, and similarly, your kidneys may also be affected. So I think it is affecting each and every part of your body. It's too wide to discuss. So for prevention, we Indians, we have a high carbohydrate diet. So for restriction of carbohydrate, weight loss, physical activity, limiting intake of alcohol, and also this thing smoking. So these are the important things that we can do, and especially avoiding a lot of sweets. Weight gain is one of the major factors which we can tackle to prevent type 2 diabetes, which is a common garden variety of diabetes which we see. Other type of diabetes are usually not preventable, but type 2 diabetes we can prevent by these lifestyle and dietary modifications, increasing more of salads and fibers in the diet, reducing carb, so that can these things can help in delaying the onset of diabetes if you have those genes. So insulin, it's a hormone which is produced by this pancreas. So insulin is an anabolic hormone. So it causes glucose utilization in fat and various tissues. Most of the body tissues are utilizing glucose because of insulin. So insulin transports, it acts on the insulin receptor and it transports and facilitates glucose entry into muscle and adipose tissue and other organs. So by which they can use that glucose as an energy source. But in long-standing diabetes, they have beta cell death. So beta cells are the cells in the pancreas which secrete insulin. So in autoimmune diabetes, drug-induced diabetes, they may have complete beta cell destruction. So this may lead to insulin dependence in diabetes. Otherwise, when HBO diabetes is uncontrolled despite on 3 to 4 oral anti-diabetic medications and lifestyle and dietary measures, we can initiate you on insulin. Sometimes when you have to undergo a procedure, for example, a big complicated surgery which requires anesthesia, then also we try to cover you with insulin. So these are the broad. And autoimmune diabetes, always we give insulin. However, in some forms we can initially give oral tablets also. So again, so dietary and lifestyle modification, weight loss, and also regularize your sleep habits, eating habits, and especially one thing is that stress is one of the factors which can increase the blood glucose levels as well. So I think these are the major in general chunk for diabetes and related disorders. But specifically, we can give certain medications like sulfonylurea group. We can give SGLT2 inhibitors. Now we have GLP-1 analogs as well. We also have metformin with us. And so these are the medications which we use to treat type 2 diabetes. For autoimmune diabetes and type 1 diabetes, we only have insulin. And for other atypical diabetes, pancreatic diabetes, insulin is usually preferred. So again, this is again a Pandora's box which you have opened. So it depends on their HbA1c levels, their fasting sugars, their PP sugars, their comorbidities. So it depends. So for example, if a patient is having sepsis or diabetic foot ulcer, if a patient is having cardiovascular disease, then they should do more frequent visits to the doctor. And if their glucose levels are getting low, especially they are having hypoglycemia, they should do more visits. So exact frequency depends on patient to patient on individual basis. But do try to get your HbA1c once in every 3 months, and especially KFT, lipid profile, complete metabolic profile. Once try to get it done in 3 months, and ECG is required in all the patients. Same goes with screening of urine for proteinuria that has to be done initially 6 to 12 monthly, depending on the patient profile. So visits have to be individualized based on the patient comorbidities and attributes of blood glucose at which they visit us. So it depends on the first presentation.